Good morning. So I've been privileged to present this topic. I can't reduce my hemorrhoids. What to do about a true hemorrhoid crisis. I have nothing to disclose. As an outline, we'll briefly review the anatomy, define what a true hemorrhoid crisis is, discuss the evaluation, treatment, and then conclude. We all know the anatomy, so I'm not going to belabor it. One thing I do want to point out, though, is that internal hemorrhoids are internal organs. I know this is redundant, but they are internal organs. When there is a crisis, these internal hemorrhoids are forced out of the anus. The internal hemorrhoids has vascular cushions and they are vascular cushions and a proximal and confluent with the dentate line. There's elastic connective tissues and smooth muscles. The external hemorrhoids, on the other hand, is distal to the dentate line and confluented in verge. The key landmark anatomically that separates internal hemorrhoids from the external hemorrhoids is the dentate line. Hemorrhoidal disease really begins with a combination of straining, bad diet, bad bowel habits. There's oftentimes increased vascularity, increased inflammation, and increased anal sphincter hypertonicity that can lead to deterioration of the trite smooth muscles and downward displacement of the cushions. Internal hemorrhoids are further classified into 4 grades. Here it is here for your review. So what is a true hemorrhoid crisis? What do we really mean by hemorrhoid crisis? True hemorrhoid crisis is when one develops acute prolapse internal hemorrhoids after a severe episode of straining, constipation, or diarrhea. The internal hemorrhoids become trapped by the hypertonic sphincter outside of the anus, incarcerating and strangulating the internal hemorrhoids. There's an obstruction of venous flow, and as the vascular sinuses quickly fill up with blood, the patient becomes incapacitated. On exam, there is severe pain. There is a massive prolapse of the internal hemorrhoids with edema of both the internal and external hemorrhoids with varying degrees of thrombosis. The external hemorrhoids really become very swollen, but never strangulated because, as you remember, it is always an external organ. Here is the dentate line separating the internal hemorrhoids, incarcerated internal hemorrhoids, that is covered by the columnar epithelium, and the external hemorrhoids that is covered by the inoderm. We all know that the hemorrhoid troubles pose a huge burden in the United States and actually across the globe as well. There are 2 million prescriptions filled per year. There's about 3.2 million office visits per year. However, the incidence of hemorrhoid crisis is still unknown. Evaluation. So when this patient comes to the emergency room, we know this patient is really in pain. They are incapacitated. They can't move. We feel sorry for them. And the young surgeon may get excited and rush to help. But just like every good doctor, you want to know your patient. You want to do a thorough history and physical. You want to know if there's any prior history of hemorrhoidectomies or any anorectal surgeries. You want to know if they have any risks or any preconditions that put them at risk of complications. You want to know if they have a history of perianal Crohn's disease, HIV/AIDS, immunocompromised states. Is there any portal hypertension? Are they on any anticoagulants? Because this all may affect the choice of management. So regardless of what management option you need to take advantage of this opportunity to teach and help and modify their risk factors if possible. So you want to talk about optimal daily fiber intake. You want to educate the patients about proper toileting habits. You also want to plan to address and work up their diarrhea or any pelvic flow dysfunction that they may have. I forgot to mention you can spell sausage without USA. So as soon as I found out that I was given this topic, considering there's no great data on this, I polled the American Society of Colorectal Surgeons Facebook group. I wanted to know who will manage these patients conservatively with limited hemorrhoidectomy or with all columns hemorrhoidectomy. What's surprising is that only 20% chose surgical approach. The arguments from the poll is similar to the reported in the paucity of data we have. Those who think conservative management is the way to go thinks that surgery is technically difficult. Majority are afraid of anal stenosis or incontinence. And those who are against conservative management argue that conservative management is tedious for the patients and the doctor, that there is considerable lost time from productive work. And I think there's always a role for conservative management for select patients. Conservative management is not the only option, just like surgery is not the only option. So what does the data show? All the data available are basically level 2 to 3 at best. There are a few case series. There's some retrospective reviews. There's one pilot study and one prospective randomized study. And some of them are actually really old and very low powered. As in March 1975, Grace and her colleagues looked at the long-term consequences of conservative management in 92 patients over 5 years. They found that 13% had no further trouble from their hemorrhoids. 55% were advised to undergo hemorrhoidectomy due to continued symptoms. All the patients actually presented with hemorrhoid crisis. Selman from Belgium in 2011, in this retrospective review, reviewed the results of 104 emergency hemorrhoidectomies versus 540 elective hemorrhoidectomies. He found that the rate of anal stenosis was 6.7% for emergency hemorrhoidectomies versus 1% for elective hemorrhoidectomies. So he concluded that emergency hemorrhoidectomy is indicated for treatment of acute complications of hemorrhoids. Emergency hemorrhoidectomy has even been done in pregnant women. In this case series, Salibi followed 25 women who underwent emergency hemorrhoidectomy while pregnant. He found that at 6-year follow-up, only 6 women required additional treatment. Mazier from Ferguson Clinic in 1972 reviewed 400 patients who underwent emergency hemorrhoidectomy over a 5-year period. In their paper, they asserted that there is no reason why any patient of average risk should not be offered hemorrhoidectomy, but that the 4-quadrant hemorrhoidectomies should be avoided because of higher incidence of anal stenosis. In 2006, the colorectal surgeons from Taiwan looked at their outcomes on 40 consecutive patients who underwent emergency hemorrhoidectomy for acute hemorrhoidal crisis. Acute hemorrhoidal crisis they define as painful fixed prolapse or strangulated prolapse leading to thrombosis, ulceration, or gangrene. They found no serious complications and concluded that emergency hemorrhoidectomy in treating acute hemorrhoidal crisis is safe and suitable. The complications are minor and acceptable. Bill Hild, we all know him in his pilot study in 1986, concluded that limited hemorrhoidectomy offers safe and innovative care, shorter period of hospitalization, fewer complications, and more effective relief of pain than any other form of treatment. The one prospective randomized study that compared urgent hemorrhoidectomy versus conservative treatment is out of the University of Birmingham, UK, showed that a conservative treatment is associated with shorter patient stay and less anal sphincter damage. Because in this study, they found that 66% had sonographically detected sphincter damage in those patients who underwent urgent hemorrhoidectomy. But the problem in this study is that 16 out of those 25 patients randomized to urgent hemorrhoidectomy were operated by a trainee. So we all know how to take take care of patients conservatively. But one thing I do want to point out is that you want to have a good, proper follow-up for these patients, so you can do a good rectal exam, endoscopies, or flexible sigmoidoscopies. So what are the tips, tricks, and techniques? Obviously, you want to give these patients appropriate preoperative antibiotics with good anaerobic coverage. I always do this under general anesthesia. I don't want to have to fight with the patient or the anesthesiologist. I have to get comfortable. It is already a difficult surgery technically. I prefer doing these things prone jackknife for adequate exposure and comfort. It also allows your assistant to actually help you well. You want to manually reduce the hemorrhoids to shrink and to reduce edema and reduce the distortion. You want to, you can inject epinephrine 1 in 200, which can aid in accomplishing this. The Fansler retractor is a must. It basically allows you to only take or remove what's available in that window. So you can get, you want to get in the habit of using this. I use this in all my elective cases, and I have not been disappointed. So you want to operate for symptoms and alone, not appearance. You don't have to cut out everything. You want to debride and take what you must. Apply the less is more approach. Leave adequate skin bridges. You may also need to just placate some smaller hemorrhoids instead of removing them. This photomicrograph is courtesy of Dr. Varud from Thailand. Here you can see the Fansler retractor in action, only allowing one to take what is in the window. Here you can see incarcerated and strangulated internal hemorrhoids. In this particular patient, they actually performed the limited hemorrhoidectomy, excising the most symptomatic internal hemorrhoid, and then reducing the rest. As you can see here, the external hemorrhoids are still intact. Here's a nice algorithm that summarizes it all for your review. In conclusion, so you want to know your patient. What risks do they have? Simply, you don't want to rush to operate. You want to understand the anatomy. When in doubt, you can choose conservative management. Remember, surgery is not the only option, just like conservative management is not the only option. Less can be more. Operate for symptoms, not appearance. Remember the Fansler retractor? That is your best friend. Manage patients' expectations. And remember, as a good doctor, this is your best time to educate the patient on proper toileting habits, on proper eating habits, and addressing their risk factors. Thank you very much.